I'd like to introduce y'all to our speaker today, Mr. Kenegos. He's a registered RM with 40 years plus working experience in the intensive care. The last 4 years, he has been the coordinator for the Arizona Medicare for All Coalition. Checking out the Medicare for All Coalition on Facebook. Ken, you're welcome to start your program.
Okay, let me see if I can do this. Technology. We're talking about what we commonly refer to as the healthcare system. But of course, I've got a couple of question marks after system because the US healthcare system is not a system. It's a market, and it's made up of financing, insurance, delivery, and payment mechanisms that remain unstandardized and loosely coordinated. And as private corporate entities, almost all of them have a legal requirement to make maximum profit. We're the only wealthy country to entrust the health of their people to for-profit corporations. So what are we getting for that? We're getting US healthcare that's accelerating in spending and worsening outcomes. The US spends nearly 18% of our gross domestic product on healthcare, which is almost double what other high-income countries spend. But Americans die younger and are less healthy than residents of other high-income countries. Not only does the US have the lowest life expectancy among high-income countries, but it also has the highest rates of avoidable deaths. Why? The high cost of healthcare in the United States. For that reason, we have 28 million people that are uninsured and an additional 25 plus million who are underinsured, meaning they have a policy, but they can't afford to use it because of the cost of that policy, the costs at time of service. This translates to about 28,000 unnecessary deaths annually, all due to the for-profit American non-system. And you can see, of course, you would expect that the decline in our life expectancy, for all of the country is 2.7 years between 2019 and 21. But if you're Black, it's 4 years. If you're Hispanic, it's 4.2. If you're American Indian or Alaskan Native, it's over 6.5 years. And, we saw this during COVID, just comparing Black to, quote, white. The hospitalization rates are practically pretty much double, and the ICU rates are over double. So we're paying so much because 31 cents out of every healthcare dollar goes to things other than healthcare. Exorbitant salaries for private insurance company executives and other executives, lobbying by the private insurers, insurance bureaucrats, a whole system paid to find ways to deny treatment. Dividends to stockholders, of course, there's the profit, advertising. And then on the other side, all the medical facilities, what it costs them to deal with the insurance companies. Every physician's office, for each physician, there's an estimated $80,000 in expenses just dealing with the insurance companies. This is an interesting slide. What do we get for that? These numbers here the number you see is the number of primary care physicians per 1,000 people. And all the other advanced countries listed above have over double, many of them, over triple the number of primary care physicians as we do per population. And that's a big factor in the kind of care we get.
Ken, I got a question for you. What is the Bismarck all-player system? I'm not familiar with that terminology.
Well, I'm not quite sure how they group that on this slide but there are countries that have what they usually call them sickness funds. And some of them have private entities running those sickness funds, but they must be nonprofit and they are strictly controlled by the government as far as much bigger regulations. Okay? It's my best definition of the. And here you can see that all these countries cover 100% or a tiny fraction under 100% of their populations. But we leave almost 15% without any coverage. And this shows you the data here is a little old. It's from 2018, but the trends are exactly the same. At the bottom where it says US, the $7,273, which is more than and almost double in some of what other countries who have a system that is basically paid for through the government pay. But ours, on top of that yellow bar, is the orange bar, what comes out of everybody's pockets. These are per person. And here's some of the reasons that it's costing so much. You can see these are deductibles, the average deductible, and how they've been going up and up and up. And here are the premiums. These numbers again are 2019. And now I know we're over $21,000 for a family plan. And then another result, of course, is medical debt. 58% of all debt collections in the US are for medical debt. I mean, you see the GoFundMe's all the time. 41% of all Americans have some medical debt. A study in Massachusetts found that 46% of residents skip needed medical care because of cost. And more than 500,000 bankruptcies related to medical debt every year. Here's some of the top 10 corporate CEO salaries. And then they go down to number 18 at the bottom. He's still over $10 million a year. Keep in mind that, the person that's the head of Medicare, which is really the biggest insurance group in the country, Medicare, they're being paid salaries in the few hundred thousand a year to run that. And these people are taking, tens of millions of dollars. And how the healthcare profiteers maintain the current non-system, and that is lobbying. And this is 2022. The pharmaceutical and health products industry spent, nearly $300 million lobbying the Congress. And in the same year, the insurance industry spent another $122 million. And this doesn't include the money they put into political campaigns. So this is, really what we're fighting against is all this, again, all these corporate money controlling our healthcare system. So what does the Medicare for All Act, which was just introduced, what it does? I mean, this is a reintroduction. The bill has been in there. There's been a Medicare for All bill, in Congress for many years. But the one that was in there in the last session now was just reintroduced. And what they do is they eliminate the excess costs for the for-profit non-system. It provides comprehensive care for all U.S. residents, including dental, vision, hearing aids, prescription drugs, mental health care, reproductive health care, and home and community-based care. It provides a just transition for those whose work is affected by the elimination of the current non-system. It ends all out-of-pocket payment, including premiums, deductibles, and copays. These things serve as, a barrier to care. If people have to pay, they're always asking the question, can I afford the medical care I need? We don't need to be asking that question. We need to get the medical care. Dedicated funding also is included to improve the medical infrastructure in healthcare deserts. Healthcare deserts are many rural areas and communities of color just don't have the facilities, don't have the doctors because the people don't have the money. And also to improve the availability of primary care. And it's paid through progressive taxation and would result in a savings. We're always told, oh, we can't afford Medicare for all. The fact is, a Medicare for all system will end up saving us about $400 billion a year over our current healthcare spending.
Where does that savings come from, Ken?
It comes from eliminating all those other things that are not, healthcare. It comes from eliminating the profit, the lobbying, the advertising, all these things that we don't need.
Mm-hmm. So would people be able to still, if they have a good job and they have a nice platinum medical plan that they like, can they keep it, or are those kind of employer-based plans going to go away?
Employer-based plans should go away. And there is no such thing as a platinum plan. I mean, they all have deductibles, premiums, co-pays.
Yeah, sure. But I mean, there are policies and procedures that make some private insurance more attractive than others, higher yearly payouts and stuff.
Yeah. But the idea that there are these platinum plans out there that cover everything and don't cost you an arm and a leg.
No, they cost.
They cost. That doesn't exist as far as covering comprehensive care.
Okay, well, Ken, are you ready for some other questions?
No, I've got a few more slides here to go through.
Okay.
And, that was basically kind of an overview of the healthcare system and what Medicare for All is and how it would replace that. I'd be glad to answer more questions on that. But there's another trend going on, and that is that these corporate entities that control our system, our non-system, are trying to corporatize Medicare, which means ending Medicare as a public nonprofit program as it was conceived. So in Medicare, and we were talking about this a little bit before the meeting, you've got traditional Medicare, you've got Medicare Advantage, And then we added something called direct contracting entities, which is now morphed into ACO REACH. And I'll try to briefly explain these. So original Medicare, you have Part A, which covers hospitalization expenses. Part B covers your doctors and outpatient expenses. You can add a drug plan, Part D, and you can also add supplemental coverage called Medigap. And then we have what's called Medicare Advantage. That is not Medicare at all. I mean, although legally they are required to offer the same services that Medicare does, one, they don't. And it is basically a commercial, for-profit healthcare plan. And most of them include the drug coverage. Some of them include extra benefits like dental, limited amounts for the most part. And they offer lower out-of-pocket costs up front. This shows that as of this year, we've surpassed 50% of all people on Medicare have opted for Medicare Advantage. And what are we finding out about Medicare Advantage? There was this huge study done that shows that Medicare Advantage plans deny needed care that should be covered to tens of thousands of people a year. Federal investigators found that out, and it came out in the New York Times around this time last year. And how do they do that? They do it through something called prior authorization, a term I'm sure we've all heard, that when your doctor orders something, they tell you, well, we can't give it to you yet. Well, you have to go through prior authorization. In other words, they have to approve it. And this shows the percentage of these different services that are subject to prior authorization through Medicare Advantage. Another way that Medicare Advantage makes money is traditional Medicare is paid on a fee-for-service basis. The doctor bills Medicare for what they're doing, and they're paid on the basis of the care that you are given. Medicare Advantage is paid up front for the patients that are enrolled. And those patients, depending on their diagnoses, have higher or lower payments associated with them. So it's a great incentive to increase their risk scores by adding more and more diagnoses. And this way, Medicare Advantage gets more money from the government. It has nothing to do with the amount of care they're receiving, only with the diagnoses. So they added many more diagnoses are added. And it's estimated that this is just in 2020, they made 12 billion excess payments to Medicare Advantage because of these added diagnoses. So these are kind of the pros and cons, which, these things draw people in, that Medicare their monthly premium may be zero. There's a maximum out of pocket per year of $7,550. It may include drugs, it may include dental, vision, hearing, and it may include a gym membership, which is a double-edged sword, which people don't realize. The cons of Medicare Advantage: there's no standardization, there's no nationwide coverage. You have your, limited choice of providers, and if you happen to be in another part of the country, that can be a real problem. You may not have any providers available to you. You may not be able to change back to traditional Medicare and a supplemental. Only during open enrollments can any changes be made. referrals required for all specialists. And again, there's this prior authorization and choice of providers limited. Very, in all these Medicare Advantage programs, the centers of excellence, such as Mayo Clinic or MD Anderson, which is a cancer center in Houston, Texas, these do not come up on Medicare Advantage programs. So they keep you away from those centers of excellence. The business of Medicare Advantage. Oh yeah, this slide has multiple things on it. Click. Medicare Advantage has been charged with it had so many suits brought against them for fraud. And when they get to a point where they have to settle these suits, they're settled without admissions of guilt. And it's part of the cost of doing business. Cherry picking. They try very much to attract the healthiest people they can. And that's one of the things about the gym memberships. They're considered a positive by people who are more healthy and are, trying to keep themselves fit. But people who aren't able to take advantage of those gym memberships, they're not a benefit to them. The expensive illnesses turn these members into liabilities, which are called lemon dropping, and they try to avoid those patients. And then again, the upcoding, getting paid for more diagnoses that don't need to be treated necessarily. And this shows the billions of dollars per year of excess payments to Medicare Advantage because of the upcoding. Medicare Advantage has never generated savings relative to traditional Medicare. In fact, the opposite is true. Kaiser Family Foundation, they've never saved money, but they're always put forward as this will save the government money. And actually, when they talk about Medicare running out of funds, this is one of the best ways to prevent Medicare from running out of funds is to get rid of Medicare Advantage. Oh, this is about AI. In 2010, an AI algorithm was sold for $6 million. It was rebranded in 2012 and sold for $50 million. It was sold to Cardinal Health in 2015 for $410 million and sold to private equity firm in 2018 for $1.3 billion. And in 2020, it was sold to United Healthcare for $2.5 billion. And what these programs do is they make it when the insurance company is doing its review as to whether they're going to pay for something, there are doctors who are supposed to look at the paperwork and make those decisions. But these programs with AI are now doing that for the doctors so that doctors who sign off on the end product end up doing thousands of denials, in a very short period of time. And that's what they're doing with AI. So between 20 and 22, the number of appeals filed to contest Medicare Advantage denials shot up 58% because of the increased number of denials. In 2022, 150,000 denial reviews were filed. So, this is what's happening. They're using this to make it faster for them to deny care. A lot of people have this idea in mind. I'll start with a free Medicare Advantage plan and pay the extra for Medigap if the Medicare Advantage plan won't let me see the doctors and hospitals I want. But there's a problem with this. Medicare Advantage opens the door to profiteering in Medicare. Traditional Medicare, 98% of the funds go to patient care. 2% is overhead. In Medicare Advantage, the insurance company is allowed to use 15% of the funds for overhead and profit. In Medicare, the Medigap, if you have traditional Medicare, there's a guarantee that you will be issued a Medigap policy if you want one, and that there will be a community rating. In other words, it will get the same, it'll cost the same in each community, not according to your health condition. But after 12 months on Medicare Advantage, those things go away. Except for in these states, they've extended the guaranteed issue. And in these states, they've extended the community rating. But all other states, they can deny you going back to traditional Medicare if you want to get a supplemental, a Medigap insurance on top of it. After 12 months, you may be trapped in Medicare Advantage. Few people realize they're making that decision when they join Medicare Advantage.
In that circumstance, if you're in Medicare Advantage for 12 months, you can't go back to regular Medicare, is what you're saying?
That if you go back to regular Medicare, you can be denied a Medigap supplemental insurance. If you're thinking, I'm going to go back to regular Medicare and I'm going to buy a supplemental and that'll be better than what I'm getting with Medicare Advantage, you may not be able to get it.
That Medigap insurance, what does that do? Cover you between the time that one policy stops and the other starts?
Medigap is regular Medicare when it was first, passed into law. It covers 80% of your medical expenses. But the other 20%, that's what you get a Medigap plan for. That's a private insurance coverage of the last 20%. And as we all know, 20% of a medical bill can be a tremendous amount. So this is about direct contracting entities. Basically, you have your Medicare card, and you have a choice between traditional Medicare and Medicare Advantage. But now we have the direct contracting entities, today known as ACO REACH, that allows private equity companies, Amazon is doing it, and all the insurance companies are doing it, to buy physicians' practices. And then they operate very similarly to Medicare Advantage. And this was originally a pilot program that was launched late in the Trump administration with the stated goal of reducing costs for Medicare and improving care to beneficiaries. The real goal is to change the way that Medicare pays for care. Instead of paying providers directly, Medicare gives third-party middlemen called direct contracting entities a monthly payment to manage seniors' care. The DCEs are allowed to keep as overhead and profit what they don't spend on medical service, a new incentive to restrict care.
So that doesn't apply to the 15% overhead limit?
These are not Medicare Advantage patients. These are traditional Medicare patients, people who chose traditional Medicare, and their Medicare primary care provider is being bought by these direct contracting entities. So it's even worse than Medicare Advantage in terms of the amount of money they're allowed to keep. So then there's been quite an outcry against this. And because of that, the Biden administration made some changes, but they didn't change the fundamentals of it. They still have third-party middlemen between seniors and the care they need. It entices private equity and other Wall Street investors to participate, and it allows middlemen to keep up to 40% of the dollars they don't spend on care. It automatically enrolls seniors without their full knowledge or consent. If your doctor's office happens to be bought by one of these private equity firms, they don't have to ask you first. It requires seniors, if you decide you don't want to participate in this program, you must find a new doctor. So it had the potential to ensnare 30 million traditional Medicare beneficiaries and basically get rid of Medicare as a public program. So it has a lot of the same problems as Medicare Advantage. Again, it's, this payment that they get for patients. So there's this big incentive to make everybody look sicker by adding more diagnoses. It sounds real good. They say, we're going to send a nurse out to your house, and maybe the nurse will do some good things for you. But one of their primary goals is to add more diagnoses so that they get more money for you. So since they're allowed to keep as profit and overhead what they don't spend on medical services, that's a dangerous incentive to ration and restrict seniors' care. These financial incentives don't exist in traditional Medicare. So equity incentives encourage profiteering in underserved communities. This is one of the big things with REACH, is they put a lot of window dressing on the REACH program regarding underserved communities. But basically, by reporting demographic data, they get more money. They get paid more money for each minority patient that they put in their program. It allows the risk middlemen to use demographic factors to increase their risk scores and thus their revenues without providing additional care. This is new to everybody, pretty much. Under the radar. REACH keeps all the fatal flaws. Middlemen between Medicare and providers, maximizes revenues by upcoding profit incentive to restrict care, and keep up to 40% as profit and overhead, and it auto-enrolls the seniors. Can include private equity. Amazon's doing this. No caps on the number of providers, beneficiaries, and states. So what happens when your primary care physician becomes part of an ACO REACH program? They send you a letter. This is the letter. And basically, if you don't respond to the letter saying you don't want to be in the program, you're in it. And if you do want to be if you don't want to be in the program, the only way is to get another doctor. They're trying to increase volume through enrollment. Asking seniors to change their primary care physician undermines traditional Medicare's promise of free choice of provider. Now you can't choose that provider anymore. But I do want to say that there has been at least a temporary victory about this ACO REACH because of all of the uproar that was brought to them by members of Congress and many of the Medicare for All organizations around the country. On February 13th, they said they were capping the program. Instead of going on to enroll all of traditional Medicare by 2030, they stopped at 2.1 million people on traditional Medicare who have been auto-enrolled in ACO REACH. But of course, we have to keep an eye on them. They could bring it back at any time they want. I mean, the person who's the head of the innovation center that started this is Liz Fowler. I don't know if anyone remembers that name. She was very instrumental in the Affordable Care Act. But before that, she was a vice president for Aetna. And that's whose hands are in all of this. On May 16th, the Medicare for All bills were reintroduced in both houses, the House and the Senate. We have 121 co-sponsors in the House, which is the highest number of original co-sponsors ever. Over half the Democratic House are co-sponsors, and we have 14 co-sponsors in the Senate, which is also the highest number of original co-sponsors. And these are just some of the signage for the different organizations around the country. This is us up here, the Arizona Medicare for All Coalition, Physicians for National Health Program. We work very much with National Nurses United, particularly on their Patients Over Profits campaign. And this is something I'd like everyone to be aware of, that National Nurses United has started the Patients Over Profits campaign. This is a pledge. We're asking members of Congress and candidates for government office to pledge not to take the big money from the lobbyists for pharma, corporate health insurers, and private hospitals. Because this is, of course, the big advantage that they have in maintaining the current non-system is all that money. And we need to know that people we're going to elect to office won't be taking that money from them. And I just threw this in here. I don't know how many people on the call are familiar, have heard about the Rural Action Summit that's taking place next Saturday in Florence. I suggest strongly that people look into it and consider going to Florence. I'll be going, and I'd be glad to give rides to anyone I can fit in my car. This is an attempt to develop strategies in rural areas of the state to make a real political difference. And I will take all the questions you have now.
Yeah, Rod Norris asks, what are the advantages for hospitals and group-based physicians with our current system? I'm not sure whether by current system he means traditional Medicare or this new Medicare program.
Well, they wouldn't be paying as much as they're paying now. And what they're going to do with it, I think it should go back to employees, but I'm not really sure how that would work.
Here's a follow-up question. If the Medicare for All program were ever implemented, would employers likely shift the current healthcare insurance premium dollars to employee paychecks?
Right. Well, this, I don't know what employers are going to do. There is, my understanding, there is taxation of employers built into the Medicare for All system. But the taxation is less than what they're paying now for the premiums of private health insurance. We did a study a couple of years ago on the state of Arizona itself. And came up with multiple millions of dollars. I don't have the figures with me right now that the state would save under a Medicare for all system. They could then be put to many good uses.
Yeah, Rod Norris has his hand up, so I think he might have a follow-up or a clarification that I didn't hit the subtleties. Rod, you want to?
Yeah, Rod, you have a question?
Yeah. Is there enough waste and overage costs in the system now that if that went away, there would not be a increase in taxes required to fund Medicare for all?
Well, some people believe that there actually is enough, to do that. If the taxation proposed with it is very progressive, so it's not the average person the average family is estimated to save about $6,000 a year from what they would pay for their private health insurance.
Okay.
That's amazing.
Got a question.
Look at all of the money that goes to things that have nothing to do with providing your health care.
Yeah.
All the lobbying, all the advertising, all the profit, all the,
Bonuses.
huge CEO salaries. This stuff is not necessary.
So Kay Davis asks in the chat, I just received a letter from Banner saying, Banner Network Southern Arizona, saying that my doctor is part of an accountable care organization. This letter comes after February 13th, 2023. What suggestions do you have for how to respond to this?
Well, I would follow up with them and find out whether or not this is actually an ACO REACH program, if there are private investors involved in it. And if there are, I don't know why the letter should have come, if the actual ACO REACH program was applied to your physician's practice before that, and the letter is just later, or whether or not, that's a really good question to find out when that became effective. The letters often, from our experience, the letters come to people months later sometimes.
Kenneth, thank you so much for sharing so much information and identifying some real concerns. We really appreciate you being here. Let's give Ken a big round of applause for being here today.
If he's available for a couple more minutes, there's still a couple questions we could throw at him.
Oh, okay. You have in the chat room. Go ahead.
Yeah. Well, one, I'd like to get mine in, which is I see parallels between this and what they've been doing here in Arizona regarding public schools, with the charter schools and then with the vouchers, trying to take that money that, is working to do a public good for free, essentially, for our citizens, and make it so that you can make a profit off it by moving it into charter schools, and those charter schools can be profit. And then even further, make it a private organization where you can cherry pick your kids, and you can lemon drop and do all that stuff to make your school look more attractive, and get a huge chunk of change defraying a private student's tuition cost. Do you see a parallel between that sort of grab for that big stream of public money in Arizona on education with this Medicare change?
I agree completely. That's exactly what's going on. These very vital services, education and health, which are, instrumental to the population, they're looked upon by Wall Street as revenue sources.
Barbara Warren wants to know who are the leaders for the Medicare for All bill in Congress, so that we can support those people who are like the key players in the push for Medicare for All.
Okay, well, in the Senate, the bill was introduced by Bernie Sanders, and I don't have the list, but you can go online and look and get the names of all of the co-sponsors. In the House, the principal sponsors are Pramila Jayapal and Debbie Dingell, and then there's 119 other current co-sponsors. All those organizations that I had on that one slide are trying to, we're encouraging everybody to reach out to their Congress people and ask them to sign on as co-sponsors, and also to pledge that they won't take money from the insurance, the health profiteers.
Louise Good in the chat points out questions. Would we have enough doctors if Medicare for All were enacted? And does the bill include money for training more doctors?
I don't know the specifics, and that's a good specific question. But yes, there's definitely going to be a push. There are funds dedicated, like I said, to, increasing the medical infrastructure. One of the big reasons that we don't have enough primary care physicians is that medical school, doctors come out of medical school with so much debt that it pushes them into the more, highly paid specialties. Now, there will be a complete re-evaluating of the payment of doctors under Medicare for All, and there will be increases to the primary care doctors and some decreases probably to the really highly paid specialists, that are making millions of dollars that don't need to. The structure of debt among students trying to become physicians is a big part of that question. And I would agree that we probably don't have enough overnight for what we need, but this will be the way to begin to increase that, primary care physician base in the country.
Okay, any other questions, Mike?
Looks like Rod Norrish has his hand up. I'm not sure whether or not he just left it up or if he has a question.
No, I do have a question. With the Medicare for All, it's always been talked about as a national effort. Is there any discussion of this happening state by state?
There definitely is. There are a number of states that are trying to do that. There are some barriers to doing it on a state-by-state basis. They have to get waivers from the federal government, so it depends very much on who is in the White House. And on that note, I just want to say, unfortunately, our president was nominated on the basis of him not being for Medicare for All. The main dividing point in the primary was Medicare for All. And, what's his name? Jim Clyburn, who was seen as the engineer of Biden's nomination for the presidency, receives more money from the insurance companies than any other member of Congress. And Biden receives a lot of money from them as well. So, this is one of the problems with doing it by states. But yes, California, New York, and a number of other states are trying to do it.
Is there a serious effort here in Arizona to try this?
and we haven't really mounted that effort. There's a lot of difference of opinion among people about whether that's a worthwhile way to use our energies because of the difficulties. Then again, the argument for it is that we know that under Biden, even there won't be, he's said that he will veto Medicare for all. And that maybe for the next 4 years after 24, the chances of getting it through nationally are diminished because we have a president that does not believe in Medicare for all.
Yeah, that could also be a strategic position to try and neutralize the issue of socialized healthcare in the 24 election. And, we could always take over the state ledge, House and Senate, and then, we can pass what we want. We'll do what we want.
Yeah, I see Paul Stapleton Smith's question. Are our senators supporting Medicare for all? Well, we have reached out to our senators, and frankly, Senator Sinema is extremely doubtful. She's always made it clear that she will have nothing to do with it. Senator Kelly, we're trying to at least get him to take the Patients Over Profits pledge, not to take their money. He did pledge on his last campaign not to take pharmaceutical money. But when we asked him about the insurance companies and all, he wouldn't go that far. But I think we're going to try to meet with him and bring that question up again.
I'd like clarification from Bridget Rice-Hesse. She says that FYI Medicaid in Arizona access began as a waiver program, and I believe it still is. Could you inform us how that informed our discussion of Medicaid for all or Medicare for all here in Arizona?
Can you hear me?
Yeah.
Yeah. Okay. So someone asked Ken if it was possible for Medicaid for all to be a program within Arizona rather than a federal program. And he said, yes, it could if we could get a waiver from the federal government. My point is that access in Arizona began as a waiver to Medicaid and still is. And its name is Access.
All right.
And I'm sure if other people have been in Arizona as long as I have, you're going to remember that because it happened in the 1970s.
Well, I don't know if it's the same type of waiver because you're talking about Medicaid now as opposed to Medicare, because the Medicare
Right.
for all bills would in essence take the Medicare program, the traditional Medicare we have, and improve it by getting rid of the 20% that you have to pay and other things and expand it. So we already have a similar program in Medicare, the basis of it. But
Right. Yeah, my only point is when you mentioned a waiver, I wanted
Right.
people to understand that we have a history in Arizona with waivers with the federal government, which would likely come from CMS, the Center for Medical Services.
That may be, but I'm not sure that these are the same type of waivers that created
Just the difference between the Medicare and the Medicaid. The Medicaid being a means-tested program for indigent folks who don't have the income to afford medical care, and Medicaid being a qualified program by age, that you reach a certain age and you become qualified for Medicare.
Right.
It can get confusing.
It can.
Okay, well, hey, a great program and, great materials, great questions. And I'm sure a lot of us have a lot of personal interest in Medicare and Medicare for all. And we might just take another look at what we signed up for.